This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.
Well, hey, friends, welcome back to another episode of the MHAN podcast. We have a good one for you today. And I think one of the things that we've been discussing over the last couple of episodes, something that's been curiously missing, I think, as far as the mental health issues across the state of North Dakota has been veterans and service members and where the resources are and what is available to them if they have a crisis moment. And so we're really excited to have our guest on here, Tammy Monsebroten. She is with us today. Tammy, welcome to the MHAN podcast.
Thanks so much.
Very excited to have you with me as always, Matthew McCleary, my co-host in crime here.
Howdy.
All right, so let's kind of maybe start at the start. Tammy, I'd love you to kind of kick off on who you are, what you do, job title, and a little bit about the agency in which you work for.
Sounds good. Like you said, my name is Tammy Monsebroten. I'm a licensed clinical social worker. I work here at the Fargo VA clinic, physically located in Fargo, and I've been with the Fargo VA for about 12 years now. My title here is Suicide Prevention Coordinator, and it's just been a fascinating, exciting opportunity, really neat position to be a part of. And when I started 12 years ago, there were 2 people in my position, and then for quite a few years, we were down to 1. And we are now a team of 4 suicide prevention coordinators and 2 case managers and a part-time administrative person. So it's really growing and it's really exciting. There's a lot of work to do and we can cover a lot of ground. As far as the agency goes, the Fargo VA clinic, we have quite a few services as a healthcare system located in Fargo, the main campus. We also have community-based outpatient clinics in many parts of North Dakota, and we also serve part of Western Minnesota. So we have clinics throughout Bismarck, Minot, Williston, Dickinson, Grand Forks, a lot of different areas trying to get to all those different, locations in North Dakota.
Fabulous. So that's going to help with some of the questions that we have later down our conversation. The first question that I have for you is kind of a general overview. Could you give us some information about how mental health has impacted or can impact service members, veterans, and their families? I know some people probably have some inkling as to how that might occur, but I think a lot of the public is very unaware about how mental health manifests for this population of folks.
Sure. That's a great question. And a lot of people do wonder, why are veterans and military members at a higher risk for experiencing mental health issues or suicide risk? And I think that the risks for veterans are the same types of risk that general community members might experience, but veterans experience these difficulties at a higher rate or a higher level than our general population. For example, exposure to trauma or death. Some veterans, military members experience these exposures more often than general population. We'll talk a lot about isolation later, and that can increase risk for suicide or mental health concerns. Veterans also have more access to lethal means, such as firearms or other access to lethal means that can be easily or impulsively used for suicide attempts. A lot of people serving in the military are people who are already at increased risk for suicide. When we look at our Native American populations, Native Americans serve at a disproportionate rate in the military. So when you look at that population being at already an increased risk for suicide and then add military service to that risk, like I said, there's a few other populations as well, or specific risks where those people already come into the military with some specific risks for suicide or mental health concerns, and we're kind of just compounding that when we add military specific risks. Veterans and military members also experience a loss at a higher rate of the general population. When people return from deployment or discharge from the military, they may experience loss such as friendships, meaning and direction in their life. They may come back and experience loss of intimate partners, relationships with family members, friends. They may have lost their residence. They may have lost a sense of identity. They experience employment difficulties in returning to the general population. And again, isolation can be a big one.
Part of the, I think as we've been discussing on the podcast here, and I think really general best practices on suicide prevention or learning to read some of the signs, I think has been a difficult conversation a lot of individuals throughout the state are having. How do you address the specific needs from the specific perspective of a service member or a veteran or their families when it comes to suicide prevention and best practices? Is there a difference between sort of civilian and these and the service members, or things that we should look out for, or best practice wise?
So best practice wise, I really think that interventions for suicide prevention are pretty much the same across the scope of best practices. However, when we're talking specifically about military and veteran families, one thing we really need to consider is the isolation that has come with that experience. And so I wanted to note that there's a Time article. It's an online article. It was authored in 2011. And the article is called The Other 1%. It's a really great article. And the reason it stands out for me since that time is that the Marine sergeant that they interviewed said, quote, "I can't talk about war without sounding like an alien. And it's hard not to think about my war as a bizarre camping trip that no one else went on." And I had those two quotes prepared because they really stuck with me. How isolating it might be to return from war and not be able to have anyone understand what you went through. And that the number of people who have served in the military recently is decreasing. It's, like I said, 1% of the population. So people who have served or people who have family members that are served, those numbers are decreasing. And so it's really easy to kind of be able to thank people for their service, buy them a drink or a sandwich when you see them in their military uniforms and move on with your day. And I think it's really important to we'll talk later about increasing that awareness and decreasing the isolation. What you specifically asked about, though, was best practices for suicide prevention. And so I do want to highlight there are some best practices like looking at public health models that are best practices. So when we think about public health models and suicide prevention, I always reference public health agendas. Like if you're at the age where you remember the egg cracking in a frying pan, where it said, "This is your brain," and then the egg cracks and it says, "This is your brain on drugs." That was a really good public health campaign because it stuck with us for, we're going on 20, 30 years now. So when we look at public health messaging and getting the word out there about mental health concerns, how to get mental health help, and how to intervene in people who might be experiencing a suicidal crisis, it's really important that we consider good public health messaging. Building community connectedness, access to emergency care, looking at the continuum of care. So looking at early access to assessments and screenings, all the way to access to emergency care. And then including family members and friends can actually go a long way in treatment planning. When we look specifically about medical and mental health interventions, there are some evidence-based preventions that can really go a long way in decreasing people's thoughts about suicide and people's willingness or ability to attempt suicide. So one of the interventions we know about that can be a really great help is called safety planning. People who help others with safety planning know that there's a 6-step process to like identify when people are starting to experience those difficult thoughts, and then who to go to, what steps to take, and exactly kind of how to move through that safely so that people don't get to the point of attempting suicide. There's some evidence-based therapies. There's cognitive behavioral therapy for suicidal ideation. There's dialectical behavioral therapy, which has been around for quite a while. It's been proven to help decrease thoughts about suicide.
So the other thing that has been developing across the country is the rollout of the 988 crisis hotline, which is touted as the 911 for this generation, specifically addressing behavioral health crises. And that's been exciting for a lot of people. Are there specific features of 988 that might be beneficial for service members, veterans, and their families?
Yeah, this is a great question. It's interesting how 988 and the Veterans Crisis Line came about. So the 988 number is the same number that you would get if you dialed 1-800-273-8255, which is the National Suicide Prevention Lifeline. And the best way to have rolled out the Veterans Specific Crisis Line was to kind of attach itself to that number. So when you call that 1-800 number or the 988 number and you press 1, you get specifically the Veterans Crisis Line. And the people who are answering the Veterans Crisis Line are VA staff members who are trained to handle any type of crisis that a veteran or family member might call with. They also have a texting line and a chat line, and those are not specific to 988. So if you were a veteran or a family service member, you dial 988, you press 1, you will get somebody that can help you out. If you want to text, you can text a short code to 838255, or you can chat online at veteranscrisisline.net. And like I said, these are VA trained responders that are there to help out in any type of crisis.
I think that actually leads in really well to the next question, because we've got such a wide, geographically large state, right? And I know that the VA is in Fargo. Given the size, given how many veterans are kind of spread around the entire state, how do service members and veterans get help if they're in the rural communities? They're not located in Fargo. It takes a little time. I know that there's numbers of like how much time you have before a suicidal thought happens, before someone executes with it. I mean, that's something that I think we think about a lot. How on earth do we serve such a large swath of geographical space for those who are in crisis mode?
That's a good question, and it's so interesting that this is one of the things that COVID helped us out with. It really pushed the issue in having virtual services. And so, in thinking about crisis services, anybody in any rural area can dial up the Veterans Crisis Line, as long as you have access to cell phone service, which most people would consider, who doesn't have access. But when you're in a really remote area of North Dakota or Minnesota, sometimes you don't have that access necessarily to cell phone service. If you don't have access to cell phone service, the best thing that I can recommend is ensuring that you have access to things that you've prepared, whether it's a written safety plan or maybe it is a smartphone app. You might have some personal data on a smartphone app. There's lots of great apps out there for mental health, for crises, for veterans. So to have those ready to go if you're not able to access cell phone service. But in general, if you're able to dial up or text or chat online at veteranscrisisline.net, these are really easy, quick ways to get help as soon as possible. And when you call or text or chat these resources, they have an amazing system to be able to get to connect you with your local resources, whether that's emergency care or otherwise. I always encourage anybody to, if you're experiencing thoughts about suicide and you need help, please go to an emergency department. Don't wait to drive from Williston to Fargo to get help, because that's a really long drive. So go to your local emergency department and we'll figure out the rest of it later, but get help as soon as possible. If you need to, if you're not sure that you're at the point of needing to go to an emergency department, call the crisis line and talk through that with them. So I always want people to know that you can call the crisis line and not have police and ambulance show up at your house immediately. You can call the crisis line. They're going to assess you for safety. And once they determine that you're safe, then they're going to talk with you through whatever is going on. And if you want them to, they will send a consult through to the Fargo VA clinic. So then we'll call you the next business day and discuss, local services or VA services and try to figure out how to get you connected. Mm-hmm. The crisis line tells us that they only send about 25% of their call volume through to us for referrals. That means that 75% of their call volume is calling just to have somebody hear them out. They need a third person. They need somebody to listen. They need some ideas. So that's really neat, I think. And when you consider their call volume, we receive about 50 to 60 consults through in a month right now. And that's only 25% of their call volume.
So there's some related questions here that we had, both in terms of, the crisis services and how veterans or service members and their families outside of the Fargo area or in rural communities receive assistance. But when service members, veterans, and their families are seeking care in the community, what can they or their service providers do to ensure that they are staying connected with the VA? And I don't know how this ties in, but you did mention earlier that you had community outpatient clinics throughout the state in more North Dakota's definition of more urban areas in our state. So we were kind of wondering how do people outside of Fargo or in other places outside of the VA get connected to services and then maintain that connection to the VA?
Okay, so I'm going to take a few steps back and talk about one of the things that I hadn't realized before I started working at the VA is that not all veterans come to the VA or qualify for VA care. I thought that if you were a veteran, you get to go to the VA and you get your care there. It turns out there's a lot of different types of eligibility criteria that go into people receiving VA care or benefits. It sometimes depends on the era or conflict that in which somebody has served. It might depend on their current income. It might depend on whether or not they have a service-connected disability. It might depend on the time that they spent in the service. So there's a lot of different criteria and different categories that people might fall into for eligibility. And some people may not be eligible for VA healthcare at all. And so I always want to remind people to start with enrolling for VA care. Go to your local veteran service office. Every county has a VSO, and ask to start the process for enrolling in VA care. Ask to start the process for applying for a service-connected condition. If you haven't done that already and you experienced any type of disability or injury while you're in the military, or one of your current injuries was exacerbated by your time in the military, apply for a service-connected condition and get the process started that way. So once you're enrolled for VA care, then you can see a VA care provider in one of those outpatient clinics across the state. And if you would like at that point, that provider can refer you to a community care provider. So, there's a few steps in the process, but when you, once you get enrolled, you see a VA provider, probably at one of those outpatient clinics. If you're not in the Fargo area, they can make a community care referral for you, and you can then kind of see a provider in the community, sometimes of your choice, if they have decided to also take part in being a community care provider for the VA. There's also, let me stop there. Are there any questions about that, the community care process?
No.
Okay.
Besides the fact that I just didn't know that everybody was automatically enrolled into VA services, I think that comes as a shock to, I think, a lot of people, where, you've got this system of, you've served, you've been a part of the whole system, and then more hoops, which I guess anybody who knows anything about government is like, oh, that makes sense. But that little portion, I don't think ever crossed our mind.
Right. Yep. And I'm glad to know that I wasn't the only one that didn't know that. One thing we want to do is encourage community providers to become more aware of and comfortable with asking if people have ever served in the military, because some people who have served, interestingly, don't consider themselves veterans. And we also want veterans to become comfortable in saying, hey, I've served in the military, I'm enrolled for VA care, I wonder how we might connect these services a little bit better. We do, again, one of the things that COVID really pushed was virtual care. So we do a lot of appointments, including mental health appointments, by virtual care. If you have a smartphone and you're, 3 hours away, 7 hours away from any healthcare provider, you can still connect to your healthcare provider via your smartphone app. We'll send you an email, you click the link, you're in a private virtual care room with your mental health provider. It's really neat, created a lot more access to a lot of veterans and really decreased travel time for people who have families and are working. There's also vet centers. We have vet centers located in Fargo, Bismarck, Grand Forks, and Minot. Vet centers are more community-based counseling centers. They're not there to be medical providers. They are counseling centers initially set up to provide services for veterans who specifically have served in combat. So I just want people to know that those vet centers are out there as well.
With all the different services that are being offered and provided, I think that probably coincides with sort of a change in narrative as regarding mental health within the veteran community and service member community. Have you noticed a change in the way that people are talking about this, the way that they're talking about it with their families, their openness? And it appears, I think, as sort of an outsider looking in, that there's a more willingness to talk about some of these items that may have been bottled up a little bit in previous generations. Have you noticed that at the VA? Have you noticed that as part of your conversation? And how does that kind of maybe change the way that you provide service based on the number of people who are more comfortable talking about it?
We have definitely noticed a change, and I think that veterans have also noticed a change. It's a slow change. It's a really difficult one. In general, people don't want to talk about these issues. They've recently, in the history, considered to be pretty personal, difficult topics to discuss. And I definitely think it's changing. And one of the things that helps it to change, there's actually a few things that have helped it change. There was a public health campaign called Seize the Awkward, and that was more directed towards, I think, youth in general. But acknowledging that this is awkward and seize the awkward, I think that went a long way in helping people to say, all right, this is weird, this is difficult, we're going to put it on the table anyway. Another thing that has helped and gone a long way is veterans and families willing to tell their story of their challenge and how they got help. There's a specific website called Make the Connection. So you can go to Make the Connection and you can hear real stories of real veterans who have experienced challenges and the treatment that they went through and how it's helped them. And what I really like about Make the Connection is that you can click in certain criteria that you might relate to. So if I'm a female veteran between the ages of 40 and 50 who served in a certain conflict, I can click those boxes and I can see stories of veterans that might have been through the same type of situation that I'm experiencing.
So, we're Mental Health Advocacy Network is a group of agencies and organizations that are very passionate about advocating for improvements to our mental health service delivery system in North Dakota. To tie it back to crisis, there was a really troubling Surgeon General's report that came out a few years ago saying that North Dakota from 1999 to 2016 had the highest rate of increase in suicides in the country. And so this is a very important thing for us to improve because we are losing people.
Yes.
From your vantage point, what ought our communities do to improve messaging, services, supports, and so on for service members, veterans, and their families?
I remember that report, and I don't ever hear about that report without getting chills, because that's huge. That number was very alarming. So again, I think some of the things that have helped to raise awareness are people telling their own stories and really getting that word out about what they've been through and what has actually helped. Improving messaging. So when we are losing people by suicide, there's some data and some information and guidance on how the media should and should not report. So kind of recognizing that and allowing for the media to help in creating supports and increase the chances that people will reach out for help versus risking the issue of contagion. There's a site called Coaching into Care. Coaching into Care is almost exactly what it sounds like. If you are a family member or a friend of a veteran and you're not quite sure how to bring up that topic of, hey, maybe we should go look at some mental health supports, because that can be a difficult topic to bring up. Coaching into Care is exactly for that. You can call this 888 number and they will talk with you about how to talk to your loved one about getting into care. One of the presentations that the VA does frequently is called VA SAVE. SAVE is an acronym for Signs, Ask, Validate, Encourage, and really getting that word out on how to recognize the signs, how to ask the question, because that can be really scary for some people, how to actually say the words, are you thinking about suicide? Validating is the V in SAVE, and either encouraging or expediting treatment, which can be a difficult decision sometimes on whether we just encourage treatment and leave it at that, or if we expedite it that exact moment when people are needing help. So increasing that knowledge and awareness, the willingness for people to ask about suicide, the willingness for people to get others help when they need it, I think can go a long way. One of the things that I hadn't talked about yet is the difference that decreasing access to lethal means can really help. And so I'm going to pause for a second because I could go on and on about decreasing access to lethal means. So before I start that, is there anything else that we were going to cover?
I do not believe so. Please continue, because this is a very interesting and sensitive subject. So continue.
Okay. All right, thank you. One of the things we talked about back with best practices that I missed at the time is called lethal means safety. And what it used to be called was something like lethal means reduction or suicide risk reduction. Lethal means safety is kind of a more positive twist on it. But there are some very specific studies that have shown decreasing access to lethal means can, in fact, decrease numbers of people who have died by suicide. So when we talk about North Dakota specifically, and that increase in suicide numbers, I really encourage people to think long and hard about our access to lethal means in this area. And it can be a sensitive subject, like you said, especially when we're talking with veterans or farmers or hunters. So recognizing that people have firearms for all different types of reasons and that they're a pretty important part of their life typically. Not here to talk about a political agenda or whether or not people should have access to firearms. What we are here to do is ensure that people are aware of the risks that come with that and to educate people on the risks. And so thinking about it like the risks that increase when you smoke cigarettes. Like, we're not going to go take people's cigarettes away, but we are here to educate people on the risks that smoking might cause for someone and to put interventions in place that might reduce their risk of disease due to smoking. So if we can put time and distance between people's thoughts of suicide and their ability to take action, it can really go a long way. There was a study that was completed where people who attempted suicide and survived said that 71% of them said that from the time they decided to take action to the time they actually took behavioral action was less than an hour. is something like 25% of them said it was less than 10 minutes, which is a really short amount of time to make a really big decision. And the important part about keeping people alive through the crisis is that most people who attempt suicide one time don't ultimately go on to kill themselves, which is really interesting that most people who attempt suicide and survive, that's their point where they get intervention or treatment. And so if it sounds kind of gruesome, but if we can keep people alive or have them attempting suicide by any other means than a firearm, we can really go a long way in saving lives. There's another study that shows that people who use a firearm, 95% of those firearm attempts will result in death, whereas only 5% of all other methods combined result in death. So all other methods, whether you think about hanging or overdose or drowning, all other methods combined, only 5% of those result in a death. So there's a few different studies. The Israel Defense Force did a study. They had a really high number of suicides happening, especially on weekends when their service members were on leave. So they implemented a policy where on weekend leave, their service members were no longer allowed to take their firearms with them. They decreased their number of suicides on the weekends by about 50%. Their number of weekday suicides stayed about the same. So they think that simply by decreasing access to firearms on the weekends, they decrease their number of actual suicides by about 50%. The other one that I find really interesting happened in Sri Lanka. And the reason I think it's so interesting is because it wasn't about firearms, it was about pesticides. Their lethal means were pesticides. They had a huge farming industry boom, and they had lots of access to pesticides that they were ingesting to kill themselves. And Sri Lanka put restrictions on the pesticides, who can own them, how you have to store them, their toxicity levels allowed. And they, over 10 years, also decreased their suicide numbers by about 50%. And again, the interesting part there is that their number of suicide attempts stayed about the same. It's just that people weren't dying. So when we talk about these rural areas and people who have access to firearms, typically, I haven't had anybody disagree with me that having access to a firearm and feeling down, depressed, or hopeless, or using drugs or alcohol, it's not a good idea. Nobody disagrees with that. And so, I don't expect people to be in a suicidal crisis for the rest of their life. But talking with people about, can we decrease your access to a firearm for 30 days, and then we'll reevaluate it. The best plan is to have it removed completely from their residence. If that's not something that people are willing to consider, then we talk about adding a gun lock to the firearm and maybe make the key difficult to get to. Have a loved one hold on to the key, put it in a different location. Whatever you can do to put time and distance between your thoughts and your actions. Some people are using their firearm for protection, and you're going to have it at their bedside and they're going to have it loaded. And so if that's the circumstance and you've had thoughts about suicide, I encourage you to put something between you and that firearm, whether it's the crisis line number, maybe it's a picture of a family member or a friend that you put there. So some of your reasons for living, maybe it's something you're proud of, a vacation you're looking forward to, whatever it is that you can put between you and that opportunity to use it to harm yourself. And not necessarily just about firearms, but we look at medication as well, and other methods. I had somebody who had considered using a rope to hang themselves. They knew which rope they'd use, they knew where they would do it. And over time, this person agreed to get rid of the rope. It was out of sight, out of mind. If this person decided to make an attempt, they would have to go to a store to buy a rope. And if they got in their car to go to the store, they had the crisis line number on their dash. So just putting time and distance and some interventions in there can really go a long way. And I hope that further discussions in this rural area can increase people's awareness and knowledge about how far we can go in saving lives if we just don't have access to firearms during that time of crisis.
Is there a way for people to have that discussion with somebody about means or harmful means reduction in reducing the risk for suicide. How does somebody start that process of having that discussion?
I'm so glad you asked. There are specific trainings on how to have this conversation. There's a training called CALM, which stands for Counseling on Access to Lethal Means. This would be a training mostly for providers who might be talking with people about it. It's like a 4-hour course, and it goes pretty in depth on how to have these conversations. But the very short answer is within the VA, we use the acronym GROW. It's getting ready for that conversation. So instead of asking somebody, do you have access to firearms? We start with the conversation of, I'd like to talk with you today about what it might mean for us to talk about lethal means. And the reason I want to talk with you about firearms is because veterans are at a increased risk for using a firearm for suicide. So kind of laying out why we're having that conversation, and then that we're here to help. We're not here to take firearms away. I have a coworker that jokes about us having a closet full of people's firearms down the hall. That's not what we're here to do. We literally cannot come to your house and take your firearms away. We are here to simply provide education and some ideas, because some people have the idea that either you have access to firearms or you don't, when really there's a lot of gray area in the middle that can go a long way in keeping people safe and keeping people from intentional or accidental death. So again, in having that conversation, think about that it's a temporary solution. I don't expect you to be in a suicidal crisis forever. Think about responsible gun ownership in general. People who feel strongly about, having their guns locked and unloaded, that's kind of a baseline responsible gun ownership idea. And then talking with people about, that we're not here to take things away from you, and we're really here to help increase the safety of you and your family. Does that answer your question?
Yes, it does.
Okay.
I think one of the most interesting things about this conversation is how direct and almost the phrase "clear over clever" these conversations need to be had. I don't think getting cute about suicide prevention and strategies by which you can give time and space between the ability to do self-harm and how direct you were. Are you having suicidal thoughts? Are you considering harming yourself? Instead of like, hey dude, you okay? And I think as someone who is who's experienced service and how direct an order is, and how there is a certain clarity here that I think is really interesting on how you've adjusted to the switching of needs and how people have kind of turned on to thinking about this differently than they traditionally have, I think is remarkable. And I think that's really where you and your perspective in the VA is kind of adjusted really well, providing all of these services and having so many access. Per usual, our listeners know that in our show notes, we'll have a bunch of links, not only to all the resources that you listed off and the Time article and on all these things we'll put in the show notes that you reference that, and including direct access into crisis lines as well, so that you, as a family member, somebody listening to this, or as a serviceman or a woman, and as a veteran themselves, if you may be listening and saying, I need to have access to these, we'll put those there as well. Mm-hmm. Tammy, thank you so much for being a guest. This is one of those things where, again, this is not an easy topic. These are not easy numbers to digest. When you're talking about what Matthew and you referenced earlier was the Surgeon General numbers about the skyrocketing numbers of individuals in North Dakota who are, disproportionately increasing and taking their lives. This is something that we really need to talk about. And I think shying away from it because it's an icky topic and it doesn't feel good and doesn't feel right, doesn't matter. Especially when lives are saved, especially the individuals who have done above and beyond duty to giving us protection and freedoms that we've all enjoyed. And I think this is something that we just should be top of mind as always. So thank you so much for your perspective. Thanks so much for your time. Thank you so much for providing all the resources for our show notes. And thank you so much for being a guest here on the MHAN podcast. We'll talk to you next in the next a little later episode. Thanks for listening, gang.
Great. Thank you very much.
This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.